Well, welcome everybody to XPC Talks. We have Justus Ruff from Pearl Health today with us to talk about value-based care. And Justus, I'll hand it over to you. Tell us a bit about yourself, and then you can jump into your presentation.
Hey everyone. Yep. Thank you for having me. Excited to dive in today. By way of background, I am the VP of operations at Pearl Health. Have been with Pearl for a little over 4 years now, and joined as Pearl's first employee. So have been with Pearl for the entire journey. Spent about 10 years in what I now know it's called the provider enablement space, but working between payers and providers, helping them perform better in value-based care arrangements. So excited to dive in today. I think we've got some interesting topics that I'm very passionate about. I know there's some great questions that got sent through ahead of time. And so excited to dive in on some of those, and hoping I can hit on many of them as we go. So, all right. I know I hit on a little bit of background about me. Also pulled up some of the other companies I've worked for. I think I've been really fortunate to work with some amazing leaders and organizations in this space. Have to give the Pearl pitch here on the start, just so everyone knows where we are and where we sit in the value-based care space. We are a primary care focused technology company that helps providers and organizations to participate in advanced value-based care arrangements. We do that through our in-house technology suite that's built to help reorient workflows around value-based care activity and align incentives around those activities and overall performance. And we are accelerated through pulling in all different kinds of data sources and generating recommendations based on that. But let's get into the fun stuff. So what I was hoping to cover today, we're going to do a VBC Economics 201. So I'm sure many of you are familiar with some of the basics. I might not get in too much into the weeds on some of the real basic concepts here. I wanted to focus on some areas that I think are often overlooked or misunderstood. And then just given that I've done a few turns of this, highlight some areas that I like to focus on when building in VBC. And then lastly, I do want to highlight that these views are my own. These concepts are mostly right. I think, as with everything in healthcare, there's always some sort of asterisk, or, oh, it always works a little bit differently in this line of business or this segment. And so what I'd like to really just hone in on are like the conceptual frameworks to look at these kinds of things, knowing that there's always going to be an exception to the rule. But ultimately, I don't feel like those exceptions are important to understanding what's going on in value-based care. And so I wanted to call that out on the front end. So where are we? I think VBC can be a bit of a buzzword at times. And I think in some ways it's because it's coming, and it's coming fast, which is great. But I don't think there's necessarily a unified definition around it. And it means very different things to different people. And so hopefully we can demystify that a little bit today. I think the most critical piece that I wanted to call out is just to help everyone understand how the dollar flows. Because once you understand that, I think the rest of how you meet the market and fit in a value-based care setting starts to make sense. So from a dollar perspective, it starts with, like any business, revenue, expense, margin. In a value-based care setting, it's the revenue's passed in the form of a premium. And so in an employer world or commercial space, it's passed as a premium. That's what it's called. CMS, similar mechanic, but they have the dollar themselves, and then pass that and delegate risk down to risk-bearing entities. And that could be a health plan, it could be ACOs, but fundamentally that dollar gets passed either directly or indirectly um, to these organizations that are then responsible for managing expenses against that. And so there's a few categories to keep in mind here. There's institutional claims, there's professional claims. So when you're utilizing care at a hospital or facility, medication, RX spend, and then there's also just organizational OpEx. So these are all areas that when you're sitting in the RBE seat, you're thinking about these and how do we manage these well, so that at the end of the day, if we do that well, based on the premium dollar that we're bringing in, we're able to generate some form of profit, which is often much easier said than done. Um, but I think is an important kind of understanding of the flow of funds so that you can understand where the dollars are moving and in what cost centers they're hitting. And so as an organization that holds risk will do is they're going to look at a variety of levers, and I'd say that this probably isn't fully comprehensive, but I think is a good starting point of when you're thinking about revenue in the seed. It's okay, what is my population, and how is that the benchmark acuity set? How am I going to underwrite and price my product so that I'm getting an appropriate amount of revenue, and then how am I going to grow lives under management so that I've got enough people flowing um, into my products that I'm able to generate revenue off them. um, Moving down to the expense category, it's how do I make sure I'm delivering a high quality um, network and delivering on quality care? How am I managing utilization across that network, and am I doing that efficiently so I'm getting the right spend in the right places, and the spend that I want in the areas that are going to be most impactful? And then how do I do that in an efficient way where it's not taking a lot of resources to help manage, and instead um, I'm doing that in a very capital light way, then everything else flows into margin, which is great. It's where everyone wants to eventually be. Uh, but then as you're thinking about, okay, I'm launching in value-based care, or, where do I fit into this spectrum? What what plans and risk-bearing entities are thinking about, or how can I spend $1 or $2 on the left here and get, $2 or $4 back. And so I'm getting return on that by investing in something like, okay, I'm going to incentivize primary care to do proactive care management. I know that if I spend $1, I'm going to get several back in that. And so that's just the framework with which these stakeholders are often thinking about this. And so where did we land from here? I think there's been if you're trying to keep track of all the programs that Medicare has spun up to try and address value-based care, good luck. It's complicated, and there's so much nuance underneath it all. Um, but it evolved to be a spectrum. So um, there's fee for service with some quality participation, um, upside only shared savings where you start to earn based on how well you um, manage cost. Risk-based contracts where not only you're open to earning on the shared savings, but if you don't perform well, you share in those losses as well. And then at the far end, it's capitation and full risk with a global budget. Um, I think across each of these, they've got advantages and disadvantages. And so a lot of where organizations find success is figuring out, okay, where am I at my starting point on this spectrum? And then um, launching there instead of focusing somewhere that's just too far advanced for them and where they're at now. um, but there's a lot of optionality here, and I think we've seen a lot of great progress as these models have evolved.
Justice, quick question on the backside. So if you had to guesstimate the percentage breakdown, where would you say are the people, delivering care across the four buckets?
That's a good question. Um, I would say the majority is probably sitting in the left side of the equation, where groups are um, in fee for service plus quality or upside only savings. I think very quickly these organizations are maturing and starting to push into um, up and downside risk, which is exciting, because that is where providers are able to earn a lot more and really get even more aligned to patient outcomes, which is, I think, back to where they want to be practicing. And I know we've seen that a lot on the Pearl end. I also anticipate more and more it, the downside risk will start to become required, so that organizations are getting pulled into it a little bit more heavily over time. And so many people in the value-based care space right now are thinking about, okay, how do I do this intelligently? How do I take the right risk when I'm ready for it? And what do I need to have in place when I'm doing that? Which I guess kind of leads me into this next slide here, which is, should I participate? One of the hardest things to do in value-based care is attribution. Um, Everyone's got a slightly different model on how they attribute you a patient, attribute you to the outcome that you're driving. In primary care, there's one method. If you're a vendor or a specialty provider, it's really got to be clearly defined on, how do I track what patients I'm driving impact on, and what those outcomes are. Am I getting credit for that, so that, if you're deploying against a certain population, and a payer or an entity is um, using a multiple solution approach, you're actually getting you're aligned with them on what that population would be, and what credit you're going to get for managing them. Um, Understanding if you really have the ability to impact costs. I think there might be points where you get the attribution right, but you don't actually have access to the levers that you need to do that and do that consistently. Um, Historical performance is key. A lot of what we do on the Pearl side is we'll do a look back over the last 3 or 4 years, and see where you're in the primary care side, where your panel has performed, what your areas of opportunity are, and then help match that with um, what program and track are best for you. And then it's easy to talk about risk in the aggregate, I think, but when you look at it, the reality is if you're looking at a risk equation, there's always going to be a bad year. And it might be you're really good, and most years are good, but you um, are able to do well otherwise. The key is making sure that you're in a position where you've got protection in case things aren't necessarily going as exactly as you planned. Some watchouts that I think I've learned along the way, and I think especially earlier organizations in this journey should keep in mind. Um, don't over index on early results. I think especially the first year, it takes time to build momentum in value-based care. And so you could have selected well in your first year, or kind of had a good performance or a bad performance in the first year. The truth is that it just takes process and systems and getting those in place to drive value over time. And so I think it's important to make sure that you're looking at it with that horizon, so that you're building and focusing on the right things, and not um, you know getting getting lucky, for lack of a better word, popping into my head in the first year and saying, okay, this thing works, when it was really just a year where people didn't um, underperform. Um, it's very capital intensive when you're taking more advanced arrangements on, and um, like, trust your actuaries on that front. Um, you've truly got to understand your data, so you know exactly where you are coming into these programs. And then healthcare will forever continue to be local, um, and relationship driven. And so what works for you in one market might not work well in another market. And so as you're scaling, it's going to get harder and harder. And so you've got to know, okay, what's going to port well from market to market, and what won't, and what are we going to have to go and learn as we're doing that, and kind of take the right bets, based on that. Um, um, I'm seeing a question in the chat. You know, what are the levers you need to have control over when, you take risk? I think that can be a very specific question depending on what population you're going at risk for. Um, and so I think it's more important for you to understand, okay, what are the key drivers of spend, drivers of quality care, and then do I have control or the ability to impact over what those drivers ultimately do? And so I think what our levers in primary care are going to be different than levers in specialty care and kind of other models. So I would just encourage you to take a look at, if if you're taking risk on a certain portion of spend, where's that spend coming? And do I have control over that? Which is a kind of a long-winded non-answer there, but that's what I got for you. So I think it's so important just to boil this down to a very simple framework in understanding, like, what are people thinking about when you're talking to them about value-based care? Um, and I've boiled this up to payers and providers. I know there's also, vendors and other stakeholders in this system. Um, but I think it's really important to understand these two verticals, because the winners and the people that are the most successful know how to simplify around some of these components, negotiate good contracts, and then drive process and systems that are not only going to help improve performance, but establish redundancy for when things aren't going exactly as planned. Um, and so for providers, I know there might be a lot of physicians on here today. I think what it often boils down to is how are you going to improve the amount of time that I can do this in? Can I do it faster? Is it going to create more work for me? Value-based care historically has been a huge operational burden from an administrative work standpoint. And so providers are understandably hesitant on participating in more of these programs where it's pulling them out of patient care. I think some of that space is starting to really evolve with AI spinning up to take on a lot of this admin work, but it's still very real. Um, Revenue and money is a big part of the equation on participating. I think that the dollars have to line up if you're in the business of um, in the business of care delivery, and then um, anything that's going to drive quality. And I think what I've seen in the provider space, especially with primary care, um, groups will have one that they care about more than the others. And so it's when you're talking to them, it's figuring out, okay, which one where are we having the conversation today? And focusing in around what's important to them. On the payer side, they're doing so much. And it might get a little confusing on, like, where do I really fit in? The truth is that there's two things they care about. It's going to be margin, and it's going to be, how do I grow? And margin's an equation of revenue minus their medical expense minus their operating expense. And so, as you're focusing conversations there, just know that you kind of want to bucket around those categories of, here's how I'm going to drive this thing for you. You might only do one, you might do multiple, but especially in a value-based care setting, I think there's a lot of ways that you can grab on and drive impact. And then ultimately, when they're doing that well, then they want to grow, because it's that's going to improve their top line. So how are you going to help them build a better offering that is more affordable, and it's going to increase membership under their plan. Um, Now, what do they each worry about? If you're a provider, it's, am I going to get paid? Am I going to get paid enough? Probably, am I going to get paid in a timely way? Um, and then what are the non-clinical complexities that this value-based care world is going to add on the payer side? And I think it's important to note, like, if you look at the getting paid part, payers are worried about affordability, and so they want to pay, but they also want to have a marketable product that they can go out and not have patients get charged too much. They worry about inefficient utilization, and I think that's a very important first word there, because the high performing payers, they actually want people to access the full amount of their benefit, and they want patients to be going in and using providers. They're in many ways, they're just trying to make sure that they're going to the right people, and using the right things at the right time. And so, I know they've got a lot of functions here that cause a lot of problems on, I think, on the left side here of what providers worry about, but that's often kind of I think, the misunderstood component of it. And then they want to have a marketable network. So, everyone wants to go to top doctors. They want to have their doctor in network. And so they're really focused on that. Um, and then what gets lost in the whole thing is that in a value-based care world, both a payer and a provider are going to win when patients are getting healthier and staying, um, getting the right level of care that's appropriate for them. It's kind of this, like, a Pareto efficiency curve of everyone's trying to negotiate against each other, and at times it can get a little tricky. But I think ultimately, having been on both sides of the equation, um, it would shock you how aligned they all are, in this equation. I think I saw some questions come in, so let me pop over the chat here. Um, so maybe I'll dig into that after I wrap. I know there's some really good ones here. I'm excited to dive into that. But let me tick through a little farther, and then we'll go. Um, so from an engagement perspective, and that's, really where I've spent a lot of my time, is how do you work with providers to get them to change behavior? Um, I don't think, sometimes people will say, like, "Oh, you got to disrupt this or disrupt that." I I do tend to roll my eyes at that a little bit, because the goal is really just to make things easier, and um, something that can be consistently executed on. And so when you do those things really well, you're going to be able to get the behavior that you often want. And driving that, I think there's four key questions here that I think, when you really boil everything up, you just need to have good answers around. Um, the first is that, when you're asking them to do something, especially value-based care related, do they understand what it is that you ask? And that requires education. It requires simplicity. It requires obviousness. Um, the second is, if they understand it, it's like, oh, okay, well, do I actually feel like I can achieve it? Sometimes these targets feel that you might be asking them to do something that, um, they don't feel like they can actually go and get done, even though it is understood. If they do it, is it going to get tracked? And if it's not tracked, it's oftentimes not done. But that recognition is really key to making sure that you're getting workflows done consistently. Um, and then the fourth one's my favorite. It's, if it's seen, do I care? Um, and oftentimes people will tie that to uh, money. Like, what's my reward and incentive at the end of this? Um, Most of the stakeholders involved in value-based care aren't actually directly incentivized and paid around, um, around some of the activity that they do. And so I just think it's really important to focus in on, what are the rewards that you're giving when the action gets completed, and that could be a variety of different things. It could be giving someone a plaque that says, "Hey, congrats, you were our top performer," or anything under the sun there. But really focus in on, what are the actual incentives I'm providing to the actual users and people that are doing the work they need to get done. Because I think once you figure out the right model there, and there's a lot of models there, you'll start to get a lot of motion moving forward. Um, One thing that I'm kind of passionate about is I don't think I know there's so much innovation happening on the care model front, and I don't want to minimize that, but especially when you're launching a business in the space, provider trust and simplified workflows just tend to build momentum and win over the long term. Um, because there's points where care models start to get duplicated. You start to get an industry standard on, this is how I should be managing this type of population. Um, but the ability to go in and kind of do that in a way that is a effective workflow is really key. And so from my experience, providers and provider organizations that are working with others in managing care are focused on, how can I make sure that my patients are getting access quicker? Um, how can I make sure that when I'm working with another organization, they're delivering top quality? And then does this partner actually improve my ability to manage care? Am I getting information back on my patients? Do I feel like I'm managing this patient as a team? And again, this might be an area that everyone can put an asterisk on, and you can probably say, here's a scenario where this might not be true, but I think more often than not is something that I've seen in the space. And then had to wrap with some random thoughts here that I think are important. I think I've said this a couple times now, but it's in the VBC space, it's workflow. And the companies that I think are going to win out over the long run are the ones that really focus on what the right go to market is and what the right partnership model um, can be with both payers and providers. Um, this quote here, I actually, with the um, stellar CTO Octavian. I got to give him credit here, but he always said people came for the money, but they stayed for the workflow. I think that sometimes the incentives and dollars around these programs are exciting, but eventually, if you're annoying and being really burdensome on the work front, people want to leave you. So because the money just becomes not worth it in the end. Um, Most of value-based care is executed by the front desk staff. It's nurses, it's MAs, it's oftentimes not the clinician, because it's all the coordination activity that are happening around care. And so how do you bring them into the fold is really where I spend a lot of time thinking. Um, for many businesses, they are launching, and I think there's a lot of cool things that you can do as you're building. But I would really focus in on, am I solving an access issue where patients needed this thing? They don't often get access to this thing quickly. They don't get it at all. Um, and you could be solving that, or you could be improving the care that they get. Um, but it's easy to go and say, okay, I want to lean into value-based care because I know all the work that I can do on the quality front. But if you're solving an access issue first, that's often where I recommend to spend time, because even just creating a tighter referral um, and improving the ability for patients to get access is really going to drive value and give you a moat um, as you're going. And then last thing, and we'll stop for questions. I think the one of the things I worry about with value based care the most is um, these metrics can be fuzzy to define, and I think we're getting better at how we're designing these programs. But when you're incentivizing various stakeholders around very specific things that you need to close, whether it's a quality gap um, or or really anything under the sun, you've got to be able to define that really well. And then as people really laser in and focus on that, make sure that that is the right thing for each patient. Um, I I think an example that I'd like to pull from is in real estate. Um, there's a pricing model called outcomes-based services that for a while was kind of like a hot thing for buildings to do, where they basically do a outcome price on, hey, I'm going to deliver this very specific thing for you, and I'll go at risk on whether or not I can do that at the right cost. It ultimately didn't work, and that was because there's so much of the process that happened in building a building where you get in, you start to dig into the foundation, you realize, okay, I actually need to shape this a little bit differently. I need to use a different kind of material for this thing because of a variety of factors, that type of thing. And so what they found was that the ability for a contractor and an architect and all the stakeholders to come together and say, hey, um, how do we solve this and get it so that we're building a really great building? Um, it started to fall apart because everyone was so focused. Well, I'm accountable for this very specific outcome, and so I think they started to lose the broader vision around it. And so when it comes to this, I think I would always look at value-based care as a long game, and you want to have success over long-term partnerships. So negotiate for getting the table as much as you negotiate for um, getting the right terms, because if you have partners on the other end that are going to sit down with you and say, hey, this is fuzzy, we're going to figure it out together, that just tends to be better in the long run. So I think that's all I had. I
Yeah,
know we're
Justus, this has been wonderful. Appreciate you enlightening us. So I'll direct maybe a question, the question that Shoba asked. Shoba, if you're around, do you want to ask it out loud? Maybe give a bit more context.
Yeah, I think just generally really looking for like more examples of things, and particularly curious because you've said this a few times about building a process for when things don't go as planned. And I'm curious, maybe like what's an example that that's looked like in practice, and how has maybe data informed even just identifying that things aren't going as planned, or where in that process have you been using the data that you have?
Yeah, I think it kind of starts with how are you tracking the key metrics that you want to drive. And so um, the earlier you're aware of when things are on or off track is always the better, because then you can develop plans around that. And I think that's where um, it can be, it's difficult, but it's really important. Um, the solutions are often redundancies. There's a lot of different strategies and ways that you can approach certain levers. So like if you're looking at a network and you see that your um, spend in one cost center is high, it focuses your attention around that so that you can go and build a strategy there. And there might be hundreds of opportunities that you can go and target. It's not necessarily that you can go and target all of them. And so the tracking and the process for when things don't go as planned, it's being able to catch that quickly and then develop very targeted strategies to go in and kind of manage against that in the right way. And I know you're asking for a specific example. I think it's kind of hard to get into specifics sometimes because populations are going to be different and everyone's dealing with different equations here. And so I think, again, you've kind of got to understand what are your levers, where's your spend going to be, what do you expect that to be, and then when you're not trending towards actual, um, what types of strategies can you go and deploy against that?
Okay, super helpful. Thank you so much.
Definitely.
And Sudeep, I know you had a bit of a comment, and actually maybe because you were in the ACO space in your prior role, I wonder if you can comment on a specific example, if you could think of something. I know you also had a
Yeah,
a hot take on a middle layer and whatever. I think you have
sure.
something to contribute to this conversation, so feel free to
No,
add.
so specific examples that we've dealt with in the past is right, trying to move patients away from hospital employed specialists because generally when you're employed, you are doing the hospital's bidding to generate more profits. You have more facility fees, and the costs are generally higher. Also, a lot of these things are still driven by fee for service contracts. and large organizations might have higher fee-for-service contracts. So you want to move patients away from the higher fee-for-service contracts to lower fee-for-service contracts. So that's generally what you're looking at. A lot of people will also say, you know, you need to figure out who your really high spending specialists are. You know, I've used this example in the past, right? You want to avoid a cardiologist who's doing like every time a patient shows up, they want to do an echo and a nuclear stress test and all of that stuff. You know, that's probably not the person that you want your patients going to. Uh, the challenge between value-based care and, you know, the old-fashioned traditional primary care when we used to go into the hospital is you kind of knew who these people are because you would talk to them. Now we no longer go into the hospital, so sometimes it becomes a little bit harder. So we're not trying to supplement that with data to try to figure out who our quote unquote high value specialists are and how do we redirect there. So it's as multiple strategies that you can take, and we've done that in the past. I will tell you, it's very hard to identify high value specialists because somebody you might identify as a low value specialist who's doing a lot of testing, there might be a reason why some patients are going there, right? And then how do you kind of identify, okay, wait a minute, these patients are going there because these are just extremely anxious, and even if I try to redirect them to a lower higher value specialist, they might actually not like that high value specialist because they want an echocardiogram and they want a nuclear stress test, and so it gets muddy very, very quickly. So I don't know if I've answered the question, but those are some of the strategies that we've used in the past. I've used in the past in my prior roles.
Yeah, I'd also just like to build on that a little. I think to some of what you were saying, it's all can just vary, and there's significant variance across that. Like, you know, I saw you said one strategy is to move patients out of hospital employed specialists, avoids facility fee. You know, and generally speaking, yeah, I agree with that. I've also seen some rural markets where they're like, we actually don't want to move that out because the hospital that we're referring into might go under if we move too much of that volume out. And it's like crazy how market to market these things can swing. And I would just encourage everyone to like really get in, know your population, know your market, and know what you can impact, because what works in one just isn't going to necessarily always pull through to another. Which means that we're not getting super specific today, but happy to dig in on strategies if you want to reach out directly too.
Alex, you had a question.
Hi, Justus. That was really fun. It's nice to see you harp on the importance of trust over shiny new toys, and robustness. So maybe over the last couple of months, I had a couple of conversations where these operators in value-based arrangements talked about this like multi-years long pendulum where there's been a growth of delegation of handing out the responsibility of let's say caps or specific quality measures to closer and closer to the patient through providers. And that's gone, you know, sometimes it goes well, but there's a ton of variability and sometimes it doesn't. And that's a huge amount of uncertainty for health plans, which are ultimately just a figment of the human imagination. It's not like a brick and mortar organization. It's like this nebulous organization that we've written into law. And so, wow, this is so much longer than I meant to say. Have you heard anything about that pendulum swinging back? About like payers saying, you know what, even if we're less good at it or for whatever reason, it's more important for us to have the hand on the wheel of making sure we hit our quality marks than it is to delegate out risk to the boots on the ground.
Yeah, I would say that the pendulum is always swinging back and forth, and so I've seen a couple turns on this where it's gone from, you know, payers saying I want to get everything that I possibly can delegated to, okay, now I need to stop that. I need to get everything that I possibly can um, like away from providers so that I can get it back in. I think there's a lot of reasons across both of those. Like, you know, right now, one thing that the industry's facing is V28, and the shifts that are happening under the IRA to Part D spend. And so if you're a health plan, you want to have a marketable provider network. And so you want them to be aligned with your outcomes. But there's a lot of unknowns right now on the Part D side of the equations. And so if you push that and delegate that out to a provider group or organization, um, you might actually put that network at harm. And so, we've seen some plans pull that back and say, we want to do this in-house. We want to figure out the model and then kind of redelegate it down the road. So I think it varies between plans. Honestly, it varies between timing.
Can I ask a quick follow-up question, Justus, if Aloysius will allow it?
Yeah, definitely.
One component that I haven't really seen delegated is the idea of care navigation. I think no one wants to hold the ball when it comes to, okay, a patient just got a referral. Now, how do they make an appointment at this independent specialist? They're all part of the same health plan. The health plan's provider lookup tools, half broken. No, and they all have a financial incentive if in a value-based arrangement to prevent grievances and make the navigation as good as possible, but no one's taking ownership of that. Is that like, or are they? How is that working in the value-based arrangement that you've seen?
Yeah, I think I've seen a few models on this front. There's standalone care coordination companies. There's plans that do it in-house. There's providers that invest heavily in their team to make sure that they're doing that well. I think the truth is that it's really hard, and there's a lot of solutions that you can go and deploy against that. And so, as far as like what's getting delegated necessarily, I think part of what a value-based care contract is doing is saying, hey, we want you to have ownership over the care coordination process, whether or not that's considered delegated necessarily.
Is that something that's been explicit, that you've seen as explicit as part of contracts and financially incentivized?
Yeah, I mean, I think when it comes to coordinating care for your patients, it's like a core thesis of value-based care. I think there's some very specific activities that may or may not get codified in, and that's some of what the payer provider conversation happens around is, hey, I do this thing, you do that thing, how can we delineate and then align incentives around what we each do well? Because in some cases a payer might say, nope, I have a solution for this, I'm doing it really well, I don't want to let it go. In other cases they might say, we don't have anything, you've got your own model, go do that thing. So it really varies. But I've seen everything under the sun.
Okay. Thank you, Justus.
Radmila, you had a question about how to get started, and I wonder if you want to add some context to it. I'm curious if you were thinking about like what are the minimum requirements for a practice to even begin thinking about VBC. I'm kind of curious if what you meant by that, but go ahead.
Yeah, no, that's exactly right. Just bringing it down to a little bit more. My question is more tactical, I guess, is as payers start to think about VBC, like, are there examples of providers or practices that have like had to start this conversation from scratch, and like how do they approach the payers, or how do you create um, dialogue where VBC seems to be the right answer in the right direction that they want to go to?
Yeah, I mean, I'd say from a primary care standpoint, it's never too early to start thinking about value-based care. Um, I think it just depends on what part of the spectrum you start on. And so a lot of that's driven by how many what's your panel density? So how many patients are actually going to fall under that contract? Um, and then what systems and infrastructure do you have in place to start? Um, and so if you're really early on, I think getting into a fee for service plus quality incentive um, model is great because you can learn about your patient population. Um, you can start to earn some extra revenue and start to build kind of the building blocks of what you need to do to be successful. And then once you get to enough of a panel and kind of enough of the infrastructure, then you can start to take a look at your performance and say, okay, maybe I am ready for a bigger bite at the apple. And plans are eager to have those conversations. They have a lot of them. Sometimes if you're small, they might take time to get to the table. But I think, they want you aligned well to their outcomes and do have these starter lanes to grab onto.
Yeah. Cool. Thank you.
Yeah. And And I'm watching the chat here. Definitely, if you're curious and want to go deeper on that, explore with ACOs. I know a great one, called Pearl Health. Would always be happy to talk to you and how we think about that. Shameless plug delivered. But it's getting increasingly harder to do this as a small practice. It's a really complicated world, and that's a lot of where we spend our headspace is how do we make it easier to do that.
Michael, if I can call on you, if you still want to ask that question that you put in earlier, Michael O'Brien, about not just process measures and biomarkers, and Justus, everyone's trying to pin you with specific examples, but Michael, I pasted it in the chat what you put in.
Sure. Hi, Michael O'Brien. So primary care doc's been involved in the VBC space for a long time. That question actually came from Sudeep's talk last time, right? So Sudeep actually made this critique of value-based arrangements around, like, you were talking about obesity as an example. You measure the BMI. Does it actually get measured? Is it actually proving any outcome that's going to work? You can lose BMI for all kinds of reasons. Many of them, like cancer, are not good for the outcomes of the patient, right? And so, like, when we do these, like you just brought up, a good entryway for a small primary care practice is do some fee for service, add some quality metrics. But then those quality metrics are these gamifiable things that actually aren't tied to relationships, to outcomes, right? So if I get really good at gaming my hemoglobin A1C measurements by dropping all my really complicated diabetic patients, which is a game people play, then I'm not actually preparing myself for a true downside risk contract where those hemoglobin A1Cs of 13 are going to be multiple ICU admissions for hyperglycemia and DKA that I don't know how to handle because I haven't trained myself to do it. So that's kind of the question. Like, what are smart stepping stones that don't get you playing the wrong game? Because the quality metrics on top of the fee for service often are a different game than true total cost of care.
Yeah, that's as you're describing this question, the only thing that's going through my head is fuck yeah, because this is where I'm really passionate and excited. I think if you look back in the last 15, 20 years, it's been value-based care spinning up, and what's your starting points? Can you figure out a couple of things that you can get people to focus on? Can you see if they actually focus on it and you can drive outcome, and then see how overall performance works? And I think, for better or for worse, that was the early stars program in MA. Fast forward to where we are right now, you've got capitation, which I think is a huge opportunity now, where we've got a lot of data that can inform that. You've got the ability to do more advanced stratification around the care, the metrics of care that matter the most. And some of that's, things like, biomarkers like you're mentioning, and get a lot more advanced on that. And start to build the incentives more broadly on, are you managing cost well? And then, we've kind of done the like training wheel approach of, here are some quality measures that are important, but if you're managing costs well and you're starting to drive on some of these key biomarkers, you don't necessarily need to have someone looking over your shoulder saying, hey, this specific metric, you drove it. Because it starts to come out in the long game. And I think the industry's starting to shift towards that mentality, and I'm really excited about. I think that's kind of where, again, I'm going to continue to shamelessly plug. That's kind of where Pearl's positioned. It's to handle that transition where it gets a lot more complicated to figure out exactly the things that are important. But one example that I harp on is that there's a lot of statin measures in value-based care. There's patients that are statin intolerant and they shouldn't be on a statin. But I've had to sit across the table from providers and say, hey, look, you're getting dinged on your quality performance. And rightfully so, they're looking back and saying, of course I'm getting dinged on this. The patient shouldn't be on a statin to begin with. The payers are saying, yeah, we agree. We're not sure what to do here, but the system is designed in a way that actually kind of doesn't set up all patients well for success. So I think I'm starting to see these different types of programs spin up that help set the table well for the next phase, which I think is going to be more like ultra specific performance targets that you can go and drive.
So I'll say, why don't we pause the recording? And I would like to ask everyone to turn on their cameras if they are able to do so. I love taking a good screenshot for posterity.